Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, Dr. Paul Nelson Williams. Paul, you ready to talk some heart failure?
I am deeply excited too. It was a great episode.
Great episode with our returning guest and now friend, I would say, Dr. Kittleson, and she taught us some fantastic stuff. But Paul, let's start with the very basics. What are the pillars of managing heart failure with reduced ejection fraction?
Yeah, Matt. So as it stands, and this will probably be outdated at some point in the future, but for right now, as far as we know, there are four major pillars of medications for this guideline-directed medical therapy for heart failure with reduced ejection fraction. And really, the patient should be on all of these unless you have a really compelling reason to not have one of these classes started. So let's go through them one by one, Matt. So the first is the angiotensin pathway inhibitors of some kind. So these are your ARNIs are probably first line. The angiotensin receptor normalizing inhibitor medications are your first line. But if you can't afford those, then ACE would actually be next in line. And if there's a reason to not use ACEs, then ARBs would be probably third line. And we're talking heart failure specifically now, and heart failure reduced ejection fraction. And we can get the nuance later on. The second pillar, Matt, is beta blockers. So metoprolol succinate, carvedilol twice daily, or bisoprolol are the recognized ones that can be used. The third pillar, Matt, mineralocorticoid receptor antagonists. So these are things like eplerenone and spironolactone are old favorites. And then your fourth pillar are the new kids on the block, which were not included in some of the studies that actually talk about these things, the SGLT2 inhibitors, which are these powerhouse drugs that we know that we love, and empagliflozin, dapagliflozin. Those are the medications that are sort of looked at and talked about there. And so, like I mentioned, really, patients should be on all these classes of medications if you can, all these four pillars, unless you have a really compelling reason not to. There have been studies that have looked at this, that if you start these medications pretty quickly after hospital discharge or within hospital discharge, patients just do better. There's significant mortality reduction and patients do better overall. And if you can't have patients on these medications, if there's intolerance, their blood pressure just tanks, so they just don't do well with them. That's actually a fairly grim prognostic indicator. But Matt, a question I think that often comes up is sort of how do we choose which one to start and sort of which one do we go with first and what order should we choose? What did Dr. Kittleson tell us? And give us some guidance there.
And this was a big reason we wanted to do the episode in general, right? Because I'm sure both you and I could name the pillars, but understanding how to start them. So she believes in rapid sequence initiation of the medications, and she said rather than start all four pillars at once, which some people do, she likes to do rapid sequence initiation because if someone has a side effect or an intolerance and you started them on four things on the same day, it's kind of hard to know what's causing that. So that just for that reason. But over the course of days to weeks, you're getting people on all these medications and up to speed. Like maybe over the course of like 6 weeks, every 2 weeks or so, you're titrating doses is what she said. And she likes to do one of the RAS blockade, like the ARNI, the ACE, or the ARB as the first line. She says and especially if you only have so much blood pressure to spend, you have to think about some of these things, but those are good ones to start off with. And then you really can go through, and the beta blocker, she said, was one of the ones she might start more towards the end because sometimes there's some fatigue. It takes a while to get the benefit of that, and patients aren't going to feel as well. So she likes to start the ones up front that might get the patient feeling better. So that would be kind of like your ARNIs, your MRAs, and your SGLT2 inhibitors. So Paul, I don't know if you've been seeing this, but I have been seeing patients now discharged from the hospital with like new ischemic cardiomyopathy, and they are on all four pillars and coming to see me for follow-up. And it's just a recent thing in the past year or two that I've seen it.
Yeah, I feel like these have been thought of largely as outpatient medications. Inpatient, you just diurese and beta block the crap out of patients, and then the rest can sort of be figured out as an outpatient. But I agree with you now. They're much more aggressive about making sure the SGLT2 inhibitors are on there. And ARNI is often sort of ordered, pre-approved, talked to the insurance company about before they even land on my doorstep. So it's been an exciting time to take care of patients with HFrEF.
Yeah, and I think the reason for that is because if they're discharged, whether or not they get started on all the right agents, that the chances of that goes way down the longer you wait to start things. So I think it's just starting it in the hospital just makes sense, or starting it at hospital discharge. So the one thing she said was for the beta blocker, generally wait until the patient is like decongested before you start that one. That's still sort of a thing that that's been around forever, Paul, and that still seems like good practice to do. But most of the rest of them, you can start them right away. And Paul, you mentioned the ACE and ARB. That there's some comparison. I was curious, or I was surprised that she said that there's actually evidence that ACE inhibitors for this specific indication, systolic heart failure, it seems like they are a little bit better than angiotensin receptor blockers. Because with high blood pressure, I'm usually going to angiotensin receptor blockers nowadays. I think you are too.
Yep.
So, Paul, let's say we've gotten our patient on all the 4 pillars. And they're feeling better, and it's 3 months later, we check an echocardiogram, their EF is actually now improved, and now their EF is 50%. Now, Paul, my instinct would be to just stop the meds. Let's wean it down. Let's put them on the minimum amount of meds possible. Is that the right instinct?
Matt, you got me over a barrel here, because I think, generally speaking, yes, that's the right instinct to deprescribe medications in general. But in this particular instance, and I'm sure there's other circumstances, it actually worsens outcomes. So the temptation is always, when someone's feeling better, if their numbers look better, is to start peeling off medications. But this has been studied fairly effectively with a really nifty trial that actually looked at this. And it turns out that if you peel away the guideline-directed medical therapy, the patients do worse and end up with kind of back where they started. So even though I think the temptation is understandable and reasonable, in this instance, you stay the course. If patients feel well, that means the medications are working, so please continue them.
Don't fall into that trap, audience. And listen, we talk about so much more. We talk about lots of other medications. Way too many pearls that we could get to in this episode. So click on the link in the description below if you would like to hear the full interview. And with that, I've been Dr. Matthew Frank Watto, and this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole. Paul?
Matt, it's always nice to spend time with you. I remain Dr. Paul Nelson Williams. Thank you and goodbye.